So now we will begin the respiratory system. Respiratory system, first of all, we will talk about the embryology, lung development. Basically, in lung development, you have to know what are the changes in different stages, and the different stages, what complication can occur if there is any error in different stages. So it occurs in 5 stages. Initial development include development of lung bud from the distal end of the respiratory diverticulum during week 4. So remember, at the week 4 there will be development of lungs. Every pulmonologist can see alveoli that will remind you of all these stages, that is embryonic stage, pseudoglandular stage, canalicular stage, saccular stage, and alveolar stage. Okay, so embryonic stage, first of all there will be lung bud. Okay, and remember the first letter of embryonic is E, so that should remind you of the 3. So that's why there will be tertiary. Okay, tertiary bronchi, third order bronchi. So that E should remind you of the tertiary bronchi. So long bud will develop into trachea. Trachea will form the bronchial buds, main stem bronchi, secondary bronchi, and tertiary bronchi. Errors at this stage can lead to tracheoesophageal fistula. Second stage is pseudoglandular stage. Now remember, pseudo is for false people, isn't it? Pseudo means the false. So false people will end or terminate. So that is how I remember the changes at this stage. That is endodermal tubules will be formed, and these endodermal dermal tubules will lead to the formation of terminal bronchioles, and that's all. These will be surrounded by modest capillary network, and respiration is impossible or it is incompatible with life. Remember that. Aspiration of amniotic fluid is essential for this stage, that is pseudoglandular stage. Now talking about the canalicular stage, just remember when I said canal, you should remind yourself that there is a track in the canal. Okay, there is some track in the canal. So T for terminal bronchioles, R for respiratory bronchioles, A for alveolar duct, and C for the capillary network. So this is the first time that there is prominent capillary network. Airway increases in diameter, respiration is capable at 25 week, and pneumocytes develop starting. Okay, so at the C stage, the first letter of C should remind of the sites. Okay, this pneumocytes start. So there might come a MCQ asking you which stage there is development of pneumocytes. Okay, and as I have written here, type 2 pneumocytes are also formed at this stage, and airway increase in diameter. Now talking about the saccular stage. Saccular stage, there will be formation of sacs, and on alveolar stage there will be formation of the alveoli. Okay, so these two stages are basically very easy. Alveolar duct will form the terminal sacs, and terminal sacs will be separated by primary septi, whereas adult alveoli will be separated by the secondary septa. In utero, breathing occurs via aspiration and expulsion of the amniotic fluid, which increases the vascular resistance through gestation. But at birth, fluid get replaced with air, and that will decrease in the vascular resistance. At birth, 20 to 70 million alveoli. By 8 years, there will be 300 to 400 million alveoli. Remember this. Now talking about the different timing. Remember, every pulmonologist can see alveoli, so that will remind you of all the stages basically. So you can see embryonic will last from 4 to around 7 weeks. Okay, so just now add 10 weeks for each. Okay, so at the pseudoglandular, just add 10 weeks. So 7 plus 10 will be 17. So that's why 7 to 17. Now again add 10 weeks. So that will be 17 to nearly 25, 26 weeks. Okay, and then 26 weeks to the birth, that will be saccular stage, and from birth to the adulthood, there will be alveolar phase. Okay, now talking about the congenital lung malformation. First, there is pulmonary hypoplasia, that is poorly developed bronchial tree with abnormal histology associated with congenital diaphragmatic hernia. Okay, usually left sided. Okay, so remember this. Why it is left sided? Again, because there is the liver is protecting the right side of the diaphragm. Okay, so at the right side there won't be any herniation. Okay, and there will be bilateral renal agenesis in Porter sequence, that can also lead to the pulmonary hypoplasia, and that is because there won't be any amniotic fluid to swallow. Okay. Now talking about the bronchogenic cyst. Bronchogenic cyst is caused by abnormal budding of the foregut. Now you see in the image there is foregut and there is abnormal budding of the foregut. Okay, and dilatation of the terminal or large bronchi. So there will be discrete round sharply defined fluid filled density on chest x-ray, generally asymptomatic but can drain poorly, causing airway compression and or recurrent respiratory infection. Okay, so that can cause recurrent respiratory infection. Okay, yeah, and it is logical also. You see, if the bronchogenic cyst is bigger, then it can cause mass effect, that is airway obstruction or recurrent respiratory infection. Now let's see what I have written from the BNB. In BNB, there is written that there is bronchopulmonary dysplasia. Bronchopulmonary dysplasia occurs in premature infants treated in NICU. Okay, so this can occur in premature infants treated in NICU. Surfactant, oxygen, and mechanical ventilation are required for the treatment. Oxygen toxicity and lung trauma can occur, and there is alveolarization doesn't progress normally in this disease. So there will be abnormal alveoli formation, okay, in the bronchopulmonary dysplasia. Respiratory problems during infancy and often improves during childhood. So basically bronchopulmonary dysplasia, the patient will have respiratory problem during the infancy, but it will often improve during childhood. Now let's talk about the some more thing that is added in BNB. Bronchogenic cyst. Okay, so bronchogenic cyst basically do not communicate with lungs, lined by respiratory epithelium. Okay, respiratory epithelium. Columnar ciliated wall contains cartilage, that is diagnostic criteria, often asymptomatic, may lead to pneumonia or compression of artery. Okay, may lead to pneumonia or compression of artery. Remember this, and that we already talked, isn't it? Now we will talk about the club cells. Okay, so club cells is nothing but non-ciliated low columnar or cuboidal with secretory granules located in bronchioles. Okay, basically on the terminal bronchioles, and degrade toxins, secrete component of surfactant, and can also act as a reserve cells. Okay, so basically they are domed profile of the membrane on the luminal surface, and lack of cilia distinguish it. Okay, so how we will recognize the club cell? Club cell, they will be domed, okay, domed profile of the membrane on the luminal surface. Okay, so there will be dome formation, and there will be lack of cilia that will help you distinguish it. And how will it degrade the toxin? That is by a cytochrome P450 mechanism. Okay, remember that can also come as a MCQ. Now talking about the type 1 pneumocytes, type 1 pneumocyte 97, that is majority of alveolar cells are type 1 pneumocytes. Okay, remember that. Lines the alveoli squamous, thin for optimal gas diffusion. And see, this is basically how our body is designed. It has to be squamous and thin so that there will be optimal gas diffusion. Now type 2 pneumocytes secrete surfactant from the lamellar bodies. Okay, white arrowhead in the picture. So here you can see white arrowhead. That this white arrowhead should remind you of the this thing called lamellar body. Okay, so these are inclusion basically. So they might ask you that what gives the type 2 pneumocytes foamy appearance, then you should tick that lamellar bodies. Okay, lamellar bodies will give the type 2 pneumocytes foamy appearance. It decreases the alveolar tension. Okay, prevents alveolar collapse, and there is a question that it can also increase the compliance. Okay, basically, and that is logical. If you decrease if you decrease the surface tension, then it will be hard to collapse, and if it is hard to collapse, then there is increase in compliance or distensibility. Okay, compliance is another term for distensibility. Cuboidal and clustered also serve as a precursor to type 1 pneumocytes and other type 2 type 1 pneumocytes and other type 2 pneumocytes. So basically it can give birth to itself and also type 1 pneumocytes. Proliferate during lung damage to regenerate alveoli. Now talking about the law of Laplace, alveoli have increased tendency to collapse on expression as the radius decrease. Okay, so you see the pressure is equals to 2T by R. Okay, if you remember from the physics, or you can memorize over here also. The more the radius, it is very difficult to collapse, and the lesser the radius of the alveoli, it is easier to collapse. You can also imagine a balloon. Okay, now if you are deflating a balloon at the final stage, it can easily collapse. Okay, remember that. Now talking about the pulmonary surfactant is a complex mixture of lecithin, the most important of which is dipalmitoyl phosphatidylcholine. Okay, this is very important, and surfactant synthesis begins around week 20 of the gestation, but mature level are not achieved until around week 35. Okay, corticosteroid important for fetus surfactant production and lung development. Type 2 pneumocyte produce two cell types and two function. Okay, so what are two cell types? Yes, type 1 and type 2 pneumocytes, and function is to produce surfactant and also function as the stem cell function. Okay, now let's talk about the alveolar macrophages. Alveolar macrophages is nothing but basically a macrophage present in the lungs. Okay, so it phagocytoses foreign materials, release cytokine and alveolar proteases. Hemosiderin-laden macrophages may be found in the setting of pulmonary edema or alveolar hemorrhage. It is also called dust cell. Okay, remember, so dust cell is another name for the macrophages in the alveoli. Now let's talk about the neonatal respiratory distress syndrome. So basically, neonatal respiratory distress syndrome means that there is lack of surfactant. Okay, so lack of surfactant. One thing I want to add is that in insulin inhibits the pneumocyte type 2 differentiation. Okay, so if there is maternal diabetes, what will happen? If there is maternal diabetes, glucose will enter the placenta, and it will trigger the increase in fetal insulin. Okay, so basically, if you see in the history that there is maternal diabetes, then this would also ring the bell in your mind that there could be neonatal respiratory distress syndrome. Okay, now as you can see over here that increased insulin inhibits the pneumocyte type 2 differentiation. This is logical, isn't it? And if you remember, to increase the surfactant, we also give dexamethasone, a type of glucocorticoid, or betamethasone. So you can imagine that in C-section delivery, there is decreased stress hormone. Okay, because there is less stressful delivery than vaginal delivery. There will be decreased glucocorticoid, and there is a risk of neonatal respiratory distress syndrome. So basically there are two risk factors. Okay, maternal diabetes and C-section delivery from the mother side, and prematurity from the baby side. Now treatment is maternal steroid before birth and exogenous surfactant for infant. The therapeutic supplemental O2 can result in retinopathy of prematurity, intraventricular hemorrhage, or bronchopulmonary dysplasia. Just imagine REEP. Okay, REEP for R for retinopathy of prematurity, I for intraventricular hemorrhage, or bronchopulmonary dysplasia. And bronchopulmonary dysplasia I have already talked, remember? Okay, now what happens in the retinopathy of prematurity? Retinopathy of prematurity, there is oxygen that leads to the free radical formation or neovascularization of the retina. Okay, now screening test for fetal lung maturity, what you will do in the screening is that lecithin over sphingomyelin ratio is measured. Okay, and if that comes to be more than 2 or equal to 2, then that is healthy, and if it is less than 1.5, that is predictive for neonatal respiratory distress syndrome. Foam stability index is another, and surfactant to albumin ratio is one more type of screening test. Okay, just remember the name, surfactant to albumin ratio. So basically there is it is also known as fluorescence polarization assay. Now persistently low oxygen tension can lead to the risk of patent ductus arterio, PDA. Okay, yes. Now you can see over here that the lecithin is the measure. Okay, lecithin is the measure that should increase, while sphingomyelin is the minor that should basically decrease, and the ratio should increase more than 2 from the graph also you can see there. Okay, as the gestational week progresses, lecithin increases and sphingomyelin decreases. Okay, okay, we'll meet in the next video.